In my presentation at the end, I made some specific comments to other targets which are under investigation, intense investigation. For example, tau pathology, which I think it's one very important target. It's very challenging since the protein is inside the neuron, and also because of the we are a bit ahead in terms of developing these drugs, but I believe this is an important line of research. And also it's important to remind that tau pathology is more closely related to clinical symptoms. So you have much more correspondence between amount and especially topographic distribution of tau pathology and clinical symptoms. So this renders this target to be very interesting to investigate. But of course, you have other targets, such as inflammation. There's much interest in the last few years in glial pathology, in glial reaction. So I think this is also another target. Synaptic changes. We know that synaptic dysfunction is an early event in Alzheimer's disease, so drugs that could act in this part would be very welcome. On the other hand, we have to remind, and I presented briefly at the end of my I presented at the end of my talk some studies on that pure Alzheimer's disease is very rare, even in early onset dementia. So the rule is to have comorbid pathology. So vascular disorders are very common, especially in older individuals. So it's almost universal when you have people with 75, 80 years or plus, that you have some degree of vascular pathology that maybe is not the main pathological substrate of dementia, but contributes to cognitive impairment. At the same time, you have other proteinopathies, such as TDP-43, for example, which is very common, especially in older ages. And some studies have shown that, for example, among people aged 80 years or older, 20-25% of them have at least 4 proteinopathies. And the more pathological actors you have, the greater the impact on cognitive impairment. So in the future, we'll need a combination of approaches of drugs to deal with these different pathological substrates: degenerative, the different proteinopathies, and vascular. For this reason, I believe that prevention is key, because you may work with regards to prevention, targeting mechanisms that are common, or at least play some role in different diseases. So we need to work a lot on prevention. And prevention is non-pharmacological mostly, or pharmacological in relation to the control of vascular risk factors, hypertension, diabetes, for example. But many other non-pharmacological approaches, such as lifestyle changes, that need to be addressed, which are much more, in terms of primary care and public health policies, are much more affordable, less expensive, and may work in terms of a worldwide approach.